by sharing her screen, I think.
My respected teachers, senior and junior radiologists, good evening. I'm Dr. Indrani Roy, working at Silat M.A. Josmani Medical College as a radiologist. My today's topic is radiological evaluation of orbital tumor. Globe is the principal structure in the orbit embedded in a fat. At first, I discuss about the anatomy of the globe. Outer fibrous layer is called sclera, inner sensory layer is called retina, and middle vascular layer is called uval tract, which consists of choroid, iris, and ciliary body. There is a three fluid-filled cavity: anterior chamber, posterior chamber, and vitreous cavity. Anterior chamber extends from cornea to anterior surface of the iris. Posterior chamber extends from posterior surface of the iris to the anterior surface of the vitreous. And vitreous cavity is the posterior segment. Anterior chamber and posterior chamber constitute the anterior segment. And there is the ora serrata. It is a serrated junction between the retina and the ciliary body. There is 7 extraocular muscle: supraoblique, infraoblique, superrectus, infrarectus, middle rectus, lateral rectus, and levator palpebral superioris, which origin from a common tendinous ring, annulus of Zinn, except infraoblique. Infraoblique origin from the maxilla. All muscle inserted into the globe behind the corneoscleral junction. Trochlea act as a pulley, and supraoblique muscle passes through it. Orbital septum. Orbital septum is a fibrous septum which separates the preseptal and postseptal space. It extends from the outer rim of the bony orbit to the inner margin of the eyelid. It acts as a barrier. Orbital septum divides the orbit into preseptal and postseptal spaces. Orbital spaces, intracorneal space inside the rectus muscle pyramid is called intracorneal space. Extracorneal space outside the rectus muscle pyramid. Orbital musculation. Within or involving the globe within the muscle cone intracorneal, arising from the muscle cone corneal, outside the muscle cone extracorneal, arising from the orbital wall. Within or involving the globe. Lesions are retinoblastoma, melanoma, detachment, and choroidal effusion. Retinoblastoma most common in children. It is 4 types has been recognized: those that are non-inheritable, those that are inherited as an autosomal dominant trait, those that are associated with a partial deletion of chromosome 13, bilateral retinoblastoma, and pineal tumor called trilateral retinoblastoma. Retinoblastoma, 90% of the retinoblastoma shows calcification. On CT image, we shows a hyperdense lesion having calcification. In case of children, calcification seen intraocular mass is highly suggestive of retinoblastoma. Contrast enhanced CT scan shows a hyperdense left globe having marked calcification. The lesion extends through the sclera into the intracorneal compartment, and retinal based calcification also noted in the right globe. Contrast NSCT shows partially calcified intraocular mass within the both globe, and contrast enhanced axial image of brain shows enhancing mass in the pineal region representing pineoblastoma. In case of retinoblastoma, we see the extension of the tumor and other site of possible tumor in brain like pineal region, suprasellar region, and fourth ventricle. In MRI, it is a hypointensity on T2 weighted image. Here we see the bilateral retinoblastoma. In bilateral retinoblastoma with the fluid level which indicate retinal hemorrhage, and left globe is enlarged in size with shallow anterior chamber. In second image, we see the right-sided retinoblastoma with focal deformity on the posterior segment of the eye and shallow anterior chamber. Here we see the exophytically growing retinoblastoma, which is hypointense on T2 weighted image and intermediate signal intensity on a T1 weighted image. The lesion shows marked enhancement. Here we show the retinoblastoma with a small nodular enhancement of the optic nerve disc, which indicating the superficial involvement of the optic nerve, and abnormal enhancement noted in the anterior segment of the eye, which indicating the tumor seeding. Here we see the retinoblastoma with a focal choroidal thickening and discontinuity of the linear enhancement of the choroid adjacent to the tumor mass is seen. In ultrasonogram, we see irregularly marginated echogenic mass having internal calcification noted in posterior segment of the globe. And here we see the shallow anterior chamber due to displacement of the lens. Without absence of calcification, there are so many differential diagnoses of retinoblastoma. One of the most common differential diagnoses is persistent hyperplastic primary vitreous. It is a congenital lesion due to presence of remnant of haloid vessels. It appear as a retrorental membrane or as a linear band which extends from the lens to the optic disc. Persistent hyperplastic primary vitreous in a 3-year-old boy, axial CT scan image shows uniform high attenuation of the vitreous. Second image we show axial T2 show haloid canal, which extends from the retrorental area to the optic disc. It is the characteristic finding of the persistent hyperplastic primary vitreous. After contrast, we see the enhancement of the fibrovascular pedicle. Ultrasonogram shows echogenic band with color flow, which extends from the retrorental area up to the optic disc. Another differential diagnosis is Coats disease. It is not a congenital disease. It is a unilateral vaginal telangiectasia, causes subretinal exudate and retinal detachment. In Coats disease, we don't see any retrorental mass. No enhancement is seen. Axial unenhanced and contrast enhanced CT image of the right orbit shows an intraocular high attenuating lesion. No calcification and enhancement is seen. Axial unenhanced and contrast enhanced fast saturated T1 weighted image shows intraocular lesion which is homogeneous with intermediate signal intensity and no enhancement seen after contrast enhancement. Differential diagnosis of intraorbital calcification. In retina, drusen's, retinoblastoma, retinocytoma, tuberous sclerosis, giant drusen's, astrocytic hamartoma, epiretinal membrane, retrorental fibroplasia or retinopathy of prematurity, and Coats disease. In retinochoroidal, chorioretinitis, choroidal, choroidal osteoma, choroidal angioma, sclerochoroidal, metastatic calcification, hyperparathyroidism, pseudo-hypoparathyroidism, renal tubular acidosis, dystrophic calcification, thyrosis bulbi, scleral calcific plaque. Choroidal osteoma, seen as a curvilinear calcification in the posterior segment of the globe, it usually sparing the optic disc. Trochlear apparatus calcification is usually seen as a small foci of calcification adjacent to the medial wall of the orbit, correspond to the trochlear apparatus. Thyrosis bulbi, the eyeball is atrophic, shrunken, and misshapen, and calcification noted within the globe. It occurred due to trauma or post-infection condition. Senile scleral calcific plug appear as a small overt calcification in the anterior segment of the globe, usually at the site of insertion of muscle insertion. Melanoma. It is common in adult. It is a lentiform convex mass which are embedded or arise from the choroid in the posterior segment of the eye. Now, non-contrast CT image of the right orbit showing choroidal melanoma. MRI images shows T1 image shows that mass is mildly hyperintense, and T2 shows that the tumor is hypointense, and T1 control shows the tumor enhanced moderately. These findings are compatible with the typical malignant melanoma of the choroid. Ultrasonogram shows a lentiform shaped mass arising from the choroid, and second image shows a choroidal mass with exudative retinal detachment. Melanoma usually arises from the choroid. It also arises from the ciliary body and iris. Here, ultrasonogram shows a ecogenic, smooth contour outlined mass in the anterior segment of the vitreous, which involving the ciliary body and iris. Color Doppler shows tumor vessels within the mass. Retinal detachment and choroidal detachment. In retinal detachment, anchoring point in case of retina, anchoring point is ora serrata and the optic disc. So complete retinal detachment appear as a funnel shape. In choroidal detachment, anchoring point is a ciliary body and a foramina of vertex vein. So it is seen as a convex indentation within the globe. Other globe lesion, drusen's and globe shape abnormality. Drusen's classification shown in the head of the optic nerve disc. Now, globe shape abnormality in globoma, there is a focal bulging noted, and usually at the insertion site of the optic nerve. It usually involves the choroid, retina, and iris. And in case of staphylomas, there is a broad bulge noted in the posterior segment of the eye, and it is located off the center from the optic disc, usually in the temporal side of the optic temporal side of the globe. There is a no focal outpouching is seen. In staphylomas, we see enlargement of the globe. In globoma, the eye is usually normal or reduced in size. Myopia, there is a epi elongation, but there is no focal bulging. Ophthalmos glaucoma is a congenital glaucoma due to inadequate drainage of the aqueous humor. CT image shows a cystic outpouching of the vitreous at the site of insertion of optic nerve. It is usually the film of globoma. And CT image shows there is elongation of the right globe with the focal deformity noted at the posterior segment of the right eye. It is the film of staphylomas. In staphylomas, there is usually the choroidal and scleral thinning occur. There is no outpouching is seen, and right globe is usually is slightly increased in size. There is a the increased size of the globe. There is some differential diagnosis. Focal deformation, non-enhancing, uvascleral bulge, usually posteriorly, is staphylomas. Optic nerve head widening with medial nasal bulge is globoma. No focal deformation, increased in every direction, microphthalmos. Increase in epidiameter, but only posterior segment. Axial myopia, increase mainly in epidiameter, both anterior and posterior segment, ophthalmos. Within the muscle cone, lesions are optic nerve glioma, optic nerve meningioma, hemangioma, and orbital varices, inflammatory orbital pseudotumor, lymphoma and metastasis, hematoma, neurofibroma. Optic nerve glioma. In optic nerve glioma, usually occur in children. There is a diffuse uniform enlargement of the optic nerve is seen. It involves the optic nerve, chiasma, and optic tract. If it is bilateral, it associated with neurofibromatosis 1. Optic nerve glioma in a 6-year-old girl with proptosis, axial T2 MRI shows an expansile mass that involves the right optic nerve and hyperintense rim at the tumor periphery reflex leptomeningeal infiltration. Axial T1 contrast fat surface image shows minimal enhancement in the mass. The nerve itself cannot be separated from the tumor. Bilateral optic nerve glioma in a 25 years old man with neurofibromatosis 1, axial T1 shows the tortuous and kinked appearance of the bilateral optic nerve. Optic nerve sheath meningioma. Optic nerve sheath meningioma usually found in the middle-aged woman. There is a mass is usually tubular. It may be fusiform or eccentric. And the mass is sharply well-defined, hyperdense, and encircle and paralleling the optic nerve. And there is a hyperostosis seen in the sphenoid bone. Optic canal is widened, but more in the glioma. Optic nerve sheath meningioma instantly found in a 50 years old woman. Axial contrast CT shows trumped configuration of an enhancing tumor surrounding the optic nerve. The mass extends to the orbital apex. Optic nerve itself can be separated from the tumor. There is a two image, and here I want to see the difference between the optic nerve meningioma and glioma. First image, in optic nerve meningioma, there no enlargement seen in the optic nerve, only the optic sheath is a large mass around the optic nerve, giving tram track appearance. In second image, we see the enlargement of the optic nerve and hyperintense rim around the mass, indicating the leptomeningeal invasion. In optic nerve glioma, we see the enlargement of the optic canal. In case of meningioma, optic canal is widened, but it is more indicating the glioma, and hyperostosis indicating the meningioma. Optic neuritis. Optic neuritis usually occur in multiple sclerosis, vasculitis, or ischemia. Uh, um, Axial T2 weighted image seen retrobulbar intraorbital part of the bilateral optic nerve is swollen, and it shows T2 high signal intensity in the both optic nerve, indicate optic neuritis. Cavernous hemangioma, most common in adult, and it is occur intracuanally. Cavernous malformation in a 46 years old man with a right-sided headache. Sagittal unhinged CT image demonstrate a round, well-circumscribed intracoronal mass that causes superior displacement of the optic nerve. Large cavernous malformation in a 43-year-old woman with painless proptosis of the right eye. T1 weighted image shows well-circumscribed hypointense intracoronal lesion causing orbital expansion. T1 contrast fat suppressed image obtained immediately after intravenous administration of contrast material shows inhomogeneous enhancement predominantly in the center of the lesion. T1 contrast fat suppressed image shows 1 hour later characteristic complete enhancement of the lesion. Capillary meningioma, commonly seen in the children, it involves the preseptal and postseptal compartment. Capillary hemangioma in a 4-month-old boy with proptosis of the left eye, inferior displacement of the globe, and a bluish discoloration under the skin. CT contrast shows intense enhancing irregularly marginated lesion with intraquanal and extraquanal component. Typical capillary hemangioma in a 2-month-old girl with proptosis of the right eye and cutaneous hemangioma shows T1 demonstrate an extracornal lobulated irregularly marginated lesion with hypointense signal and a small serpentine phlovoid areas. T2 fat separate image shows some same lesion with slight signal hyperintensity. Characteristics find internal septation and phlovoid area. T1 contrast fat suppressed image demonstrate homogeneous intense enhancement of the lesion and provides delineation of the phlovoid area. Orbital varices. Mainly, supraophthalmic vein is involved. Orbital varices confirmed by the Valsalva maneuver. Dilated vein appear as a lobulated mass. Bilateral orbital varices in a 27-year-old woman with a sensation of the eye pressure whenever stooping to pick up her child. Contrast CT shows the patient at rest shows enhanced and slightly elongated soft tissue lesion, and contrast enhanced obtained during Valsalva maneuver shows marked distension of the typically orbital varices. Orbital varies in a 33 years old woman with proptosis when straining shows T1 weighted image shows a patient in supine position, well circumscribed triangular homogeneous hypointense retrobulbar lesion. T1 contrast facet image shows when patient in supine and prone position, homogeneous intense enhancement of the lesion is seen. Enlargement and distension of the lesion features help to confirm the diagnosis of an inferior ophthalmic vein varices. Arising from the muscle cone, inflammatory orbital pseudotumor, thyroid ophthalmopathy, rhabdomyosarcoma. Inflammatory orbital pseudotumor, it causes periscleritis, myositis, perineuritis, and dacroadenitis. It involves the muscle and also the tendon, and fat extending area is also seen. Here, contrast CT shows enlargement of the left optic nerve, thick and enhancement of the left optic nerve, enlargement of the right lacrimal gland, and enlargement of the extraocular muscle in the left orbit. In T2-weighted image, hypointense retrobulbar lesion is seen, and T1-weighted image, which is the intermediate signal intensity on compared to the extraocular muscle. After IV contrast, the lesion shows slight heterogeneous enhancement and surrounding the optic nerve and adjacent fatty tissue. Thyroid ophthalmopathy. Thyroid ophthalmopathy, mainly the muscle is involved. Involvement of the muscle inferior rectus, middle rectus, and superior rectus, then lateral rectus. The muscle in only muscle involved, not tendon. And there is increased fat content in intraorbital fat content is increased. CT image shows enlargement of the muscle, extraocular muscle, inferior rectus, middle rectus, and superior rectus. Mainly, here see the enlargement of the middle rectus muscle in the both orbit. Rhabdomyosarcoma occur in the children, and it involve the superior nasal compartment. It occur in the orbit, nasopharynx, and paranasal sinuses. Primarily or secondarily, it involve the orbit. Here we see the contrast enhanced CT image. See the mass in the centered in the right ethmoid sinuses, causing bony destruction involving the right orbit and also involve the left ethmoid sinus. T1 contrast with fat saturated better demonstrate the enhancing soft tissue mass and its extension. The mass invade the medial orbit, displacing right medial rectus laterally and causes proptosis. On coronal, the mass is again seen invading the adjacent sinuses and obstructing the nasal passage. Abnormal enhancements seen in the frontal dura. Dural thickening and enhancement are compatible with the direct tumor invasion. Outside the muscle cone, orbital cellulitis, abscess, lymphoma, metastasis, dermoid and teratoma, lymphangioma, lymphohemangioma spread from lacrimal gland tumor. Orbital cellulitis and abscess. It is common in children. It appears as a ill-defined, broad base against the bony orbit is usually found. It occurred spread from infection of the face or paranasal sinuses. Contrast CT shows soft tissue thickening of the right preseptal region, and retroorbital fat is normal. Axial image of CT scan of the orbit with contrast demonstrates sinusitis of the left ethmoid sinus and both ethmoid sinus. There is a left-sided preseptal cellulitis anterior to the left orbit, and there is a left-sided subperiosteal abscess between the medial wall of the left orbit and left medial rectus. Lymphoma. Lymphoma occur in the adult and it usually affects the superolateral aspect of the orbit associated with the lacrimal gland. CT shows bilateral orbital lymphoma, two homogeneous mass in both superior and lateral quadrant. In, T1 contrast enhanced MRI, we show the hypointense lesion, retrobulbar lesion involving the intraconal fat, which is hypointense on T1 weighted image and encasing the optic nerve. It is more prominent in the left orbit. Metastasis in case of children, ing sarcoma, neuroblastoma, Wilms tumor, leukemia. Adult, breast, lung, renal cell, and prostate carcinoma, direct extension of the squamous cell carcinoma from paranasal sinuses. Metastatic breast cancer in a 43-year-old woman with bilateral paradoxical anophthalmos. Axial T1 shows abnormally hypointense and heterogeneous bilateral retrobulbar fat, and T1 contrast fat suppressed image shows patchy enhancement of the retrobulbar fat. Left middle rectus muscle also thickened because of metastatic involvement. Dermoid and teratoma common in children. Common location is lacrimal fossa, nasal bone, zygomatico-frontal suture, and frontoethmoidal suture. Now, contrast NSCT shows a cystic lesion noted in the extraconal superior middle aspect of the orbit having fat and fluid. Inflammatory change is also seen. Cyst wall is thickened and enhancing, and there is a focal interruption indicating the ruptured orbital dermoid cyst. Lymphangioma and lymphohemangioma. It is involving the extracornal, intracornal, and preseptal involvement. Appear as a large lobulated mass occur in children, and we see the venous lymphatic malformation in an 11-year-old boy with progressive proptosis of the right eye and lateral displacement of the globe. Axial non-control CT scan shows multiple fluid level with a lobulated predominantly extracornal lesion feature typically of lymphatic malformation with an intralesional hemorrhage. Axial T2 fat suppressed MRI image shows multiple fluid level within the lesion which has both intra and extracornal compartment. In lymphangioma, we see the different stage of hemorrhage. Spread from lacrimal gland tumor, lymphoid and epithelial tumor, lymphoid benign reactive lymphoid hyperplasia lymphoma, epithelial tumors, pleomorphic adenoma, adenocystic carcinoma, mucoepidermoid carcinoma, malignant mesothelioma. This MRI image, I want to see the pleomorphic adenoma. It involves the lacrimal gland enlarging the left lacrimal fossa and bony remodeling is seen. The lesion is the hypointense on T1 headed image and T2 headed image. It is hyperintense. Contrast enhancement is seen. The disordered adjacent globe and causing intermedial displacement of the globe. There is no bony erosion is seen. Here we see, I want to see the adenoid cystic carcinoma. In adenoid cystic carcinoma, involvement is orbital lobe of the gland, and it is a destructive lesion, causes the bony destruction, and it involves the optic nerve and lateral rectus muscle. Adjacent dural thickening indicate the intracranial extension. Arising from the orbital wall, metastasis lymphoma, Langerhans histiocytosis, invasion by ethmoidal or maxillary antral tumor, ethmoid mucosal spread of ethmoidal and antral infection. Langerhans histiocytosis, we see the osteolytic mass lesion in the superolateral aspect of the orbit. Superolateral aspect of the orbit after IV conference, it shows enhancement. Thank you.